and go into the off state more readily at different times and for unknown reasons in some cases, DBS actually helps level that fluctuating course out quite a bit. It does not replace medication necessarily. That's a common misconception about deep brain stimulation. It is in and of itself an additional treatment in Parkinson's disease, but in a lot of cases it allows reductions in medication, which can be beneficial for a lot of patients. So the number one thing that it does, and really where it shines, is reducing the dramatic fluctuations that can occur with Parkinson's disease. The second thing that it's very good at is reducing medication-resistant motor symptoms. That's tremor, rigidity, bradykinesia or slowness of movement, dyskinesia or disordered movement and hyperactive movement, and also sometimes dystonia. Dystonia being the cramping and toe curling, that sort of thing that can happen in Parkinson's disease. It's very good at helping that in a lot of cases. And then, like I mentioned, it does actually help reduce medications in a lot of patients, but it doesn't replace medication. So I just want to be clear about that specifically. What doesn't it do? It certainly does not slow the progression of the disease down. There's always questions that are asked of me in clinic as far as, does this actually stop Parkinson's? Does it slow it down? Does it increase my lifespan? The answer to those questions is no, as far as we know. There is a lot of research looking into what's called the neuroprotective effects of DBS, but so far we have no evidence to suggest that it actually slows down the disease. What it does do, though, and the reason that sometimes people might ask that question, is that it gives you a better quality of life for that period of time that you have, whatever that may be. So in some cases, it can seem that it slows down the disease because life becomes better on DBS for a lot of patients. But as far as we know, it doesn't protect the brain from becoming worse with Parkinson's disease. The other thing that's very important to mention about DBS, and one of the major limitations of it, is that it does not help non-motor symptoms. What that means is that, and as we all know, Parkinson's affects every facet of your body when you're afflicted with the disease. The DBS is only really good at helping motor symptoms, though. It's not good at helping memory decline, cognitive decline. It's not very good at helping balance. In fact, in some cases, it can worsen balance. Another thing it's not good at helping is voice volume. So patients who have lower voice volume with time, DBS actually does not improve that. In fact, in some cases, it can seem to worsen it, especially in patients who have DBS that's placed on both sides of the brain. Sometimes patients can get a little bit of a constriction in their speech with stimulation. So in some cases, patients may think that this actually made their voice volume slightly lower or worse. That can sometimes be an unintended side effect of the system, but in and of itself, it doesn't actually improve voice volume. The other thing that it doesn't help that often is freezing of gait. What I mean by that is patients who are walking and then suddenly freeze. I tell you that it helps movement related problems, but for whatever reason, it simply is not very good at helping gait related issues in patients. Now, there are some patients that do get benefit with freezing of gait with DBS. Typically, those patients are people who have improvement in their freezing of gait when they're in the on state, but not patients who have freezing of gait in the, excuse me, so let me back up, sorry. It does help in some cases patients who have freezing of gait that is only in the off state, but not in the on state, but it's not very good at helping patients who have freezing of gait in the on state specifically. So these are things I talk to every patient about that I meet in clinic, and I always like to put them out there because I think it's important when you're talking about this therapy to understand what it's capable of doing and what its limits are. The other thing that DBS does not do, it really, in most patients, doesn't eliminate the need for medications completely. Although I do have patients who are able to come off of a significant amount of medication, if not all of their medication in rare circumstances, but we don't use the therapy as a substitute. It's an adjunct or an in addition to your current therapy. And I think that's important to mention. So this is just a schematic of what the system looks like. It's really 3 parts. And what I mean by that is that there are really 3 components to the system. On each side of the brain, it's the same thing, basically. So this is showing what's called a unilateral or a one-sided DBS system that's implanted in this cartoon patient here. And so the first part of the system is an electrode that goes from a small hole in the skull, and you can see that right there, kind of this little cap that's right here. There's a hole that we make in the skull, and the electrode is fed through the brain very slowly through a safe area in the brain down to the target that you're trying to modulate. And in Parkinson's disease, there are two targets that we typically use, which we'll talk about here in a few minutes. But this electrode is what actually touches that target. And this is supposed to show that here on this middle picture. So the actual brain lead goes through the brain down to this area. And that's where it's parked or docked, basically, so that this is where the influence of the system is created and what actually does the business end of the therapy. This is just the other target in DBS, the subthalamic nucleus, or STN, is just showing a different pathway that the lead can take depending on the situation. That electrode comes out of the brain, out of the skull. It's secured here with this little button, basically, that is secured to the skull and holds the lead so that it can't move. The rest of the wire then goes underneath the scalp, kind of towards the back of the head, a little bit above the ear, where it's then connected to another wire that's called an extension wire that goes from the head, underneath the skin, down the neck, into the chest. This extension wire is a little more sturdy and more rugged than the electrode that goes into the brain, and it's designed to be like that because when you move your head, it has to be able to put up with, turning your head and moving around. In fact, this extension wire here is slightly thicker than the lead that goes into the brain, and it's also flexible and bendable. It has some elasticity, so it's built for wear and tear, basically. Then the third part is the actual battery pack or simulator, or I call it the IPG, which is the medical term for this actual battery pack here. In some patients, we are able to take both sides of the brain and wire them to the same battery pack in the chest, or we can split them, meaning that the electrode goes into the target here, it's connected to the extension wire and the neck, and it goes down to a battery pack on this side of the chest. And then if there's another side, if there's another system on the other side of the head, that can also go down into another battery pack. So there are some patients that have one battery pack on each side, and that battery pack drives its individual lead. So what are the targets? This is also a common question that I'm asked. And for Parkinson's disease, the two major targets are the STN and the GPI. There are differences between the two, but there's a couple things to note with them. So number one, the way that we choose targets today is different than what was done in the past. Used to, what would happen is patients would be seen by their neurologist, typically a movement disorder neurologist. They would decide that this patient is a good candidate for deep brain stimulation, and then they would choose a target based on the patient's characteristics. So this patient, for example, in a hypothetical situation, this patient has more tremor than the average patient. So sometimes I would say, I think those patients would be better served with this target. Or this patient has more rigidity. I think they'd be better served with this target. We know now that actually these targets, it doesn't really matter which one is implanted because they're both equally effective. And that's been studied in a large multi-center study showing that they are equivalent as far as the outcomes are concerned and the motor improvement with deep brain stimulation. So how we choose targets now is based on the neuropsychological profile. So that's why patients have to undergo neuropsychological testing prior to deep brain stimulation surgery. The reason is because depending on what neuropsychological testing is able to find, it then directs our decision, one target versus the other. Both of these targets, though, are good. They both work just as well as one works just as well as the other one. The differences are very subtle. The STN allows typically a much larger medication reduction for patients. So sometimes patients who if their major goal is to reduce their medication requirements, the STN is actually a better target for those patients in a lot of cases because there's a more robust medication reduction when that target is implanted. The downside of the STN is that it can sometimes worsen underlying psychiatric problems such as depression and anxiety, which are present in about 70% of patients with Parkinson's disease. It can also worsen underlying cognitive problems. So there are some patients who have worsening cognition as part of the progression of their disease, and they may not be as good of candidates for STN implantation as someone else who doesn't have early cognitive issues with their neuropsychological workup. The other option is the GPI. The GPI really is a safer target for patients who have underlying cognitive or psychiatric problems. it doesn't tend to worsen those as much as STN can in some patients. The difference with GPI is that it doesn't have as large of a medication reduction benefit as STN in a lot of cases. However, I do have patients who have DBS in the GPI into that specific target, and they were able to significantly reduce their medications, more so than I even anticipated. So it just depends. But for the most part, head to head, the thing to know is that the STN target usually allows a bigger medication reduction, and GPI doesn't usually have as big of a medication reduction. Sorry, my dog's barking. Hold on one second, let me mute my system here. Just a second. So the difference with GPI is that it is associated with a slightly higher risk of brain bleeding in some patients. However, that's very low risk in general. The brain hemorrhage risk with patients who have DBS implanted is about 1% or less, regardless of the target. There's just a slight uptick in risk with risk of brain bleeding in GPI by a very small margin, but still we have to mention that. So here are the targets. On the left, this is the GPI target. So this is an MRI of a patient's brain that I pulled from a research paper. And what you're looking at are these two arrows that show these little black dots. This is actually where the electrode is placed in the brain on either side. This patient had bilateral deep brain stimulation implantation, and this is in the GPI target itself. So this is in the deep core of the brain. That's why DBS is called deep brain stimulation, because the actual electrodes go deep into the brain. This area of the brain is sort of your motor circuit. It's what regulates movement. It doesn't generate movement, but it regulates it. And so putting an electrode into that area can help modulate that system and help refine those movements, help tremor, help rigidity, help bradykinesia, the things that are very common in Parkinson's disease. On the right is the typical STN target. It looks like a little face here with two eyes. This is a little bit deeper into the brain than the GPI. And these little green crosshairs are actually where we choose to implant the electrode for the STN target. This is a schematic just showing how I actually plan these cases in the operating room. On the left is the GPI target, and how we do that is basically finding this area here. So imaging is very important, or MRI imaging specifically, so that we can identify the structure, and then what we do is actually measure it. And we try to put the electrode in the posterior 1/3 of this structure here. So this is what I was trained to do, and why I did my fellowship was to learn how to do this very well. And usually the better positioning of the electrode, the better the outcome. On the right is just another picture showing how we target the STN. What's done there is the electrode's put basically just in line with this little circle here that's called the red nucleus, and it's parked again in kind of the posterior 1/3 of the structure. And this is all based on previous research. I certainly can't take credit for any of it. It was done by people that are very intelligent and have done lots of research as far as where the perfect or most optimum place for the electrode is. Obviously, if your electrode is placed poorly, if it's placed too far over to the right or too far over to the left, it can cause untoward side effects. But the important thing to note here too is that on these pictures, this is a very, very compact or kind of cramped area in the brain. So even if the electrode is placed very well, specifically, let's say for STN, let's say it's parked right here in the middle, and the electrical field of influence, is a little bit bigger than what the actual size of the electrode is. With enough power, that field can get bigger and bigger and bigger, and it can actually influence the surrounding or neighboring structures, which is why some patients can get side effects with DBS, because sometimes the amount of power that it takes to get a treatment effect is so much so that it actually can cause side effects. And so that's just the nature of where these structures are at in space. So how is this done? The classic way DBS is implanted is via the awake method. And I'm sure most people have probably heard of that or seen videos even of patients who've undergone awake deep brain stimulation treatment. With awake surgery, what its purpose is basically is to confirm that the electrode is where the surgeon had planned it to go. That's really what it's for. So it really doesn't make it more accurate or better. The whole reason to do it is so that we can confirm that the electrode is where we intended it to be. It's been done awake the longest. And the way that it's done is patients are lightly anesthetized in the operating room. A frame is placed onto the patient's skull, and you can see this right here. This is the exact same system that I use at OU. There's pins that go through the skin into the skull, and this is anesthetized with local anesthetic, so it's numb. And then the patient lays in bed, and this arc, or this kind of half moon here, is hooked to the other side of the frame. And then what we do is make an incision, drill a hole in the skull, and then drive a small microelectrode recording device. It's like a tiny little needle down into the target to where we had picked, like I'd shown on the previous slide. Once we're near that target, we listen to the brain. What the brain sounds like is this. Static. But basically, this is how we're trained we're trained to listen to these patterns of sound. This pattern specifically is the STN. People say that it sounds like raindrops on a tin roof. It kind of does. So basically, whenever we place that microelectrode down to the target, we listen for this pattern. And the sounds do change as the electrode is deepened into the brain. Once we have a good run or a good pass, which means we had good signals or good recordings, we then take that microelectrode out and replace it with the deep brain stimulation electrode, which is what we use for final implantation. At that point, we can then test that electrode to see if it helps symptoms. So that's the way that DBS has been implanted for years and years and still is in a lot of centers. In fact, we do this at OU. It's done at other places as well. There are some pros and cons to this. And so one of the benefits of awake implantation is that it allows the patients to see, immediately what type of benefit they could potentially expect with their DBS system. And it also allows us to make sure that the lead is really in a good spot. It's just another way to confirm that it is where you want it to be. The downside is that patients have to be off of their Parkinson's disease meds for about 12 hours before surgery. So what that means is that patients come in the off state for awake surgery. It's a big, big ordeal for patients who have Parkinson's disease to undergo surgery in that state. And so a lot of patients that I've met, especially, number one, don't want to have surgery awake. Who could blame them? And number two, the downside is that they have to be off medications. And in some cases, being off Parkinson's medications can cause severe pain or things like that. And so some patients simply cannot tolerate being off their medication for that surgery. That being said, the asleep method was developed. This is actually a picture at UCSF where I did my fellowship. This is where this technique was developed, and it's actually one of the reasons I wanted to do a fellowship there, was learn how to do this technique. So basically, this is a newer method compared to the one I just described, which is where patients have to be awake for the surgery. With asleep deep brain stimulation surgery, the surgery is done in the MRI machine. In fact, this big device here is an MRI magnet. And you can kind of see a patient laying here inside this bore, and they're draping this out. So what this does is allows the patient to come in and have the surgery done completely asleep without having to have any recording, have to be off their medications or those sort of things. The way that it does this is that we're able to operate in the MRI environment with titanium instruments and special equipment so that it's not magnetized. And basically, we convert our normal MRI machine at OU into an operating room. It has all of the same things an operating room has. It's just they're special because they're not magnetic. So patients are placed into this magnet bore here. This plastic frame, which is disposable, is mounted to the head, and then the system tells us exactly how to aim the electrode to place it precisely in the target that we want. The difference with this and having awake surgery is that with a sleep surgery, I can see the electrode exactly where it is in real time, as opposed to having that surgery done in the awake fashion. We don't have an MRI machine in that fashion where we can actually see the electrode. Instead, we have to listen to the brain to confirm where the electrode is going. This method gets around that because we can actually see where the electrode is at. So it's doing the same thing that we're doing with the awake DBS implantation, but it's just doing it with imaging instead of listening to the brain, and you don't have to be awake for that. The other thing about this is that patients can continue their medications right up into the procedure, which honestly is, I think, a lot easier for patients, and typically they recover from anesthesia somewhat faster because they're not coming in in the off state for surgery. And this has been studied, awake and asleep. Basically, this exact method utilizing an MRI or the ClearPoint system is actually the actual platform that we use, compared to the traditional awake method, and the results are equivalent. They're the same. So there is no benefit for the outcome of treatment awake versus asleep. It really just comes down to patient preference, and that's actually how my practice is too. I let patients decide what they want to do, and that's what we do. Now, there are obviously some patients who cannot get MRIs, and this technique cannot be used for some of those patients. So we do have to use the more traditional or awake method in those patients. So there are 3 device manufacturers right now that have FDA-approved DBS systems in the United States. And here's just a couple pictures I pulled off the internet from each of them. On the left, this is the Medtronic system. They've been around the longest. And in fact, they were the only company for a very, very long time with DBS systems. The reason Medtronic got involved with DBS for Parkinson's disease is because they made pacemakers. And so these devices are sort of an advanced version of a pacemaker, basically. So that's how they got involved in DBS in the first place. But they've been around the longest. The other 2 are newcomers, and one is Boston Scientific, and the other is Abbott. And there are different pros and cons to these systems, although they're all getting pretty caught up around the same level pretty quickly. So it's really, I think, eventually just going to come down to preference alone, as opposed to different benefits one versus the other. But they're all very good systems. You really can't go wrong with any of them. It's not like one is substantially better than the other one. There are different benefits one over the other, and we'll talk about those, but there's not like one is half rate or something like that. They're all very good. So you may hear or read about something called directional DBS leads, or current steering leads, or segmented leads. This is just a graphic that I use to explain this to patients. So the standard deep brain stimulation electrode is what we call a conventional brain electrode. And this is a picture of one on the left of the screen here. You can see there are 4 metal contacts here, and those are completely concentric metal contacts. So the electricity is driven through the wire down to these 4 contacts, and then that electricity then spreads into the brain target where the electrode sits. Now, the electricity spreads evenly with the conventional electrode, meaning that every direction gets the same amount of energy. There's no preference right versus left. It just expands in the same area. A directional lead allows what's called current steering. And the way that that's done is basically these metal rings are split into thirds. So one metal ring is now 3 individual pieces, and these are individually driven by a wire that's inside the electrode here. So what that allows is it allows the programmer or the neurologist to activate, say, this contact here and this contact, which then influences the electrical sphere off to the center. And it can allow steering of the current one way or the other. Now, the benefit of that is in some patients who have very sensitive brains to different side effects, or let's just say that the electrode is in a really good spot, but at whatever power, the patient has a side effect like some speech issues, or they have some tingling or something along those lines. The idea is that this directional lead can then steer that power away from the area that's causing the side effect that's undesirable. At least that's what it's meant to do. Now, the 2 companies that have directional leads currently available are Abbott and Boston Scientific. And they're called different things, but they're the same thing for all intents and purposes. It is known as a directional, a segmented, or a current steering DBS electrode. The Abbott system does not have a rechargeable battery. They have only non-rechargeable batteries available in their portfolio. And they have a directional lead. Their battery has what they consider to have the longest battery life on market, but there is no rechargeable option with their system. So basically, that's what you get with Abbott, is a directional lead and a battery that is non-rechargeable, but has a longer battery life than their competitors. At least that's what the company says. So take it for what it's worth, but that's what their system has. The Boston Scientific system, it also has a directional lead, and it has a very good rechargeable battery. And that's really where they shine, is in the rechargeable battery sphere, so to speak. Their non-rechargeable battery is not MRI conditional, at least not yet. So I only mention the rechargeable battery, and I only implant the Boston Scientific rechargeable battery at this time because I do think that MRI compatibility is extremely important for patients when they have their device implanted. The Abbott system is also MRI conditional, meaning that you can get MRIs with that system. You can get MRIs with the Boston Scientific system, assuming that you have the rechargeable battery. They do have a non-rechargeable battery, Boston, but it is not MRI conditional or compatible at this time. So those are the two new guys that are on the block. The old standby, or the longest on the block, is Medtronic. Medtronic currently only has a conventional lead. However, there is research and development into directional lead. They were actually the first to research directional leads, but for other reasons, they ended up not bringing that to market. What Medtronic has currently, the newest, hottest technology that's out there for DBS, is something called sensing technology. This was something that was heavily researched at UCSF, where I did my fellowship. And I just want to briefly touch on what this actually is, because I do think it's a real leap forward with patients with Parkinson's disease, and I want to try to explain what it does. So with Medtronic, you can get either a rechargeable or a non-rechargeable battery. It's MRI conditional. It doesn't matter which system you get. And one of the benefits is this new sensing technology. So what this is basically some research was done showing that there are different brain signals that occur in patients with Parkinson's disease. So if you have a deep brain stimulation electrode down to the target at different disease states, so for instance, this little graph on the right kind of shows this as best as it can be shown, I think. So what this is showing is that at different frequencies, or almost like radio stations, right? So at this radio station, the brain is causing dystonia. At this radio station, this different frequency, the brain is causing tremor. At this radio frequency, the brain is causing bradykinesia, and so forth. So this was discovered basically that we can actually listen to the brain and determine what the body is doing without even seeing it, right? So the idea being that if you can place an electrode into someone's brain and listen, it can tell you when the patient's symptoms are at their worst. So it can tell you that a patient had bradykinesia for 4 hours at this period of time, or they are currently bradykinetic, and it allows you then to change your programming based on that. Now, this is in its infancy, but what is available right now is this recording or sensing technology, meaning that the battery pack itself can listen all the time to the brain, and then the neurologist can look, and it almost creates a virtual diary of the Parkinson's symptoms. So they can tell the clinician, okay, between 8 a.m. and 10 a.m., you had really significant off symptoms here. I can see that on your recording, and this is sort of an example of that. And then they can make adjustments to the system to try to counteract some of that. Eventually, the hope is that the system will not need human input to make those changes. So the hope is that over time, once this research is completed, that the system itself will make those changes. So it will be able to detect when someone has bradykinesia and alter its own stimulation to help that, and then detect when someone has tremor and alter its own stimulation to help suppress tremor, so that it can be active and flexible with patients. So that's a really hot new area of technology. That is not quite available yet, where the system can change what it senses. But what is available is this system where it can listen to the brain and give clinicians valuable information in some cases. So that's one of the newer technologies that's out there. That's really all I have. I hope to open this up to questions. So if anyone has those, this is the new bed tower that's actually just about to open. In fact, it is open for some COVID patients right now. It's turning into the COVID-19 wing, because we, as everyone's probably heard, are in a bed crisis right now in Oklahoma City with patients who have COVID. So, but its grand opening is basically next month. It's a really nice facility. We're really proud of it. So again, this is my email. Anyone can feel free to email me. I do try to get back to people as soon as I can. Sometimes that can take a little while. And then the office phone here, in case anyone needed to call to make an appointment or have any questions or something along those lines. So again, I'll open it up to questions, and thank you guys very much.
Yeah, Dr. Connor, one question I received is, what is the typical time or time frame from the time a person decides they want to have the surgery until they actually have the surgery? How much time usually elapses there?
That's a good question. So basically, I'll paint a hypothetical situation just to kind of give you an idea. So once the movement disorder neurologist and the patient decide you're a good candidate for DBS, then they make that referral. I can see patients within a week actually in my clinic, but typically, that's the referral gets sent to me or to my office. Then they call the patient, schedule an appointment. So from the moment they see me, we talk about surgery and the option, what the risk, benefits, alternatives are. It's about an hour-long visit where we go through everything. We talk about different options. The next steps usually, it depends on the referring neurologist, but every patient has to have a couple things before they undergo surgery. Number one, they have to have had a neuropsychological assessment. That's so we can pick the target appropriately. That usually takes a couple weeks to get someone in to have that testing done. We do have an expedited process at OU for patients specifically of Parkinson's disease so that they're not having to wait months for that appointment. But I would say on average, it takes about, I'd say 3 to 4 weeks to get in to see neuropsychology and get that testing done. The other thing that has to happen is patients have to have had an MRI of their brain within the past year. Even if they're going to have an asleep or MRI guided implantation, I need to see an MRI to make sure there's nothing that we need to worry about or something hasn't changed dramatically, or God forbid, someone got a brain tumor or something like that, and something along those lines. So it's a safety thing. After that, it's scheduling really, and it comes down to availability of our OR time or MRI time if we're doing a sleep or MRI guided DBS, and also patient preference. So most of the time we are able to get patients in very quickly. We really did work through quite a backlog during kind of the COVID period. So now we have, we're sort of back on track, so to speak. We're not having to play catch up as much as we had a few months ago. So normally by the time that testing is done, I'd say time from when a patient meets me to implantation as of today, probably looking at maybe, I'd say 1 month would be pretty quick. 2 months would probably be pretty average, I would say, as far as when a patient could be scheduled for surgery. Sometimes we end up getting into a situation where we can't, this week in November is out, so we have to do December, and so that could push it out. But we're pretty flexible as far as getting patients scheduled for the most part. Sorry, I can't hear you, Bruce.
There's a couple questions that popped up in the chat box. Can you see those?
Yeah.
Okay, great.
So it looks like if someone currently has DBS and has had it for several years, is there a way they can upgrade their system? Is it worth it? That's a good question. So what I would say is that it's a complicated question. You can certainly, for instance, if you have a Medtronic DBS system, you can upgrade your battery to the new sensing battery, or the Percept battery is what it's called. What I would say is that, honestly, I wouldn't go and upgrade the battery just because. I would say that it's better to wait until you're needing a replacement to upgrade it at that point. Just because there's always risk with any surgery, and you wouldn't want to go for something like that and get an infection or something along those lines. But as far as upgrading the system or changing the system to like a different manufacturer, I'm not a huge fan of that. And the reason is because we don't have good data to support that. So I have done this for patients where I've changed their system to a different type of system, but it's a big ordeal to do a revision, because the issue is that there's always the chance that we won't be able to get the same benefit that the patient had with the new brain lead placed. And it is an additional electrode pass into the brain in that situation. So there's some risk with that. But it's always a discussion that we have. And I would say that if you're getting benefit from your system, it's really the old Oklahoma adage, don't fix it if it ain't broke, because you can always be worse, and that's just the truth with any kind of surgery. Nothing's ever a guarantee. But as far as the batteries are concerned, yes, that can certainly be upgraded. And that's actually, not an uncommon thing. I have patients who want to switch to a rechargeable battery, for instance, or patients who need a new battery. We can upgrade them to the new Percept battery, for instance, which is the sensing battery. That battery also has about 13% additional battery life compared to the the previous addition, so to speak, of that battery. So there are some other benefits with it, but I wouldn't do it prophylactically. I would always recommend, waiting until you need that battery replacement, and then happy to do it at that point. There are some people who will mix systems. That gets a little bit dicey in some situations, but it just depends on the situation. Everyone's different, and there are some patients that's helped. There are some patients that it hasn't really changed much, but I would say that if you're just getting no benefit from your system whatsoever, if you have DBS, maybe reasonable to consider a revision or something along those lines. But if you're getting benefit, it's always possible to lose that even with the best intentions. Let's see. When the new battery pack for Medtronic becomes available, will the replacement surgery be simple? Yeah, I mean, really, it's no different than just a normal battery replacement. So the new battery is available. It's called the Percept, and it's able to sense or listen to the brain, as well as do the normal DBS stimulation. That surgery is relatively simple as far as surgery goes. It takes about 30 minutes. It's outpatient, meaning that you come and go in the same day. And the way that surgery is done is we reopen the incision where the current battery pack is at. We go into the pocket where the battery pack's at. We take it out. We remove the wires. We get the new battery and program it with the previous settings that you had. Bring that into the field, connect the wires, lock it, and then put it back into the pocket. Most people do really well. They go home the next day, back to their old selves, usually by the next day or so. It's a relatively straightforward procedure. Normal recovery time, that's a good question. So what I tell people, ideally, it's best to say, take 4 weeks off after surgery. Sometimes that's not possible, but in general, it's about, I'd say 3 to 4 weeks before you feel kind of back to your old self, ready to go. And that usually coincides with initial programming. So the way that surgery is usually done, or the sort of sequence of events, is that a patient comes in for surgery, be it awake or asleep DBS. We do the surgery. Usually the surgery is done in 2 parts. Sometimes it's not, it just depends on the situation. But some people have what's called stage 1 DBS, which is we put the electrodes into the brain. Then stage 2, I usually do the next week, where we implant the extension wires and the battery pack. And then usually about 2 to 3 weeks after that, patients are programmed, because I don't turn the device on, the neurologist does, and begins the initial programming. So this surgery is sort of 50-50, meaning that 50% of it is me implanting the system. The other 50% of it is the neurologist programming it. And so most neurologists, and I agree with this, wait about 3 to 4 weeks from initial implantation before programming. You technically can turn the system on the next day or day of, but the difference is that you kind of end up hitting a moving target, because the brain has just had something done to it and it's constantly changing and healing. And so it may be that if you turn the system on the next day after surgery, you may have a good setting, and the next day it's totally wrong. You have to change it again and change it again and change it again. So clinicians like patients to be a little bit away from the actual surgical implantation before they actually turn the system on and program it. That means everything is kind of settled down, and then you're ready to go. But in general, it's about 4 weeks, roughly, before patients are, I would say, pretty much back to their old selves at that point. Describe typical percentage of improvement. That's a good question. So what I tell patients is that, in general, when we're talking about DBS, I say, imagine your best on state, okay? Not your best on state 10 years ago, but your best on state recently, and I'd say, okay, imagine that, and imagine that I can get you to about 70% of that, maybe 50 to 70% of that. That's about what DBS can do on its own, okay? So that being said, what it really is able to do is gives patients a stable baseline of treatment. And then additional medications are, still being taken on top of DBS. And so it helps reduce those dropouts and that fluctuation. It helps level things out. So what I would say is that, most patients get a very significant improvement. In fact, DBS is one of the least explanted devices in humans. The reason is because most patients benefit from it. What I mean by that is it's very rare for patients to not get benefit and simply want the system removed because it's not helping them. It usually helps a lot. Some people will tell you it changed their lives. Some people will say it helps some. Everyone has a different experience, and it really does come down to good implantation, so a good installation, and good programming. and you have to be the right candidate for it as well. Which those things are complicated, and that's why we, do these, with we have different clinicians that are involved. But I would say if you wanted to put a percentage on it, really, like say best case scenario, it would get you to about 70% of your on state as far as how good that feels in and of itself, no meds. Outside of that, there's a range, right? So, and Parkinson's disease is, it kind of changes as you age and that sort of thing. So those, improvements can change over time, but in general, that's what I tell patients, and that's held true.
Okay, Dr. Connor, thank you so much for sharing your expertise with us tonight.
Sure.
Fielding some questions, and did a great job. Really helped us to get a better sense of what this is all about. So thank you. Thank you very
Absolutely.
much.
I really appreciate the opportunity.
Yeah. Well, again, we're really, I got to tell you guys, we're so fortunate to have Dr. Connor here in Oklahoma. Again, to have a fellowship trained neurosurgeon. This is just really fantastic. Again, my name is Bruce McIntyre. I'm with the Parkinson Foundation of Oklahoma. And so I'm the executive director. And what the work that we do is really all about inspiring hope, transforming life for Parkinson patients and families in Oklahoma. As I said at the beginning, we want to equip you with the knowledge, the opportunities, and the courage to live as well as you can with Parkinson's. And so we put out support groups and exercise opportunities and learning opportunities. You can do, anytime you wonder about something, you can give us a call. You see Brian Martre's number pops up there. If you're wondering, he's with Medtronic. If you're wondering about that, give him a call. You can email him, Dr. Connor, very accessible. You can email him. You see in the chat box, there's his email address. And so don't be afraid to ask questions or to reach out to us. We're not that scary. We're here to help. So we're glad that you guys have joined us tonight. And we'll end this session and let you get along to what's next for the evening. And we have others coming up next week. If you go to parkinsonoklahoma.com, you'll see the schedule. And all the sessions that we're doing this month will be resurfacing as we go through the coming months. So thanks so much for joining us tonight. Thank you.
Thanks, Bruce. Sorry about my dog barking.